My name is Shaylin Sluzalis. I'm an April board member, and I'm wearing a couple hats today that I'll explain a little later on, and facilitator of today's call. And thank you all again for joining us for Project Alive, which stands for Accessible, Life-Saving, Integrated Vaccine Equity, on identifying barriers and increasing access to COVID-19 vaccinations among the disability community. I want to mention a few housekeeping items before we get started. First, when you scroll over the screen, a menu bar pops up. Depending on what device you're on, you can find that menu bar at the top or bottom of the screen. And that is where you will find the closed captioning for today's session. You can view the captioning by selecting the CC tab on the menu bar, and you can also adjust your settings for the captioning in that setting as well. Apologies, do we have Spanish cap today in this session?
No.
Okay, thank you. We do have sign language interpreting though, and you can find the interpreter on screen if you would like to change the size of the screen. If the slides are shown, you can select the line in the middle to make the slides larger or smaller. And I don't believe we will have slides for this session today, so please don't hesitate to let us know if you have any technical support needs in the chat. And you can use the chat feature for that. And in the you can also find the word bubble in the same menu bar to find the chat using the word bubble in the menu bar. And if you would like to turn the chat feature off, if you are using a screen reader, you can do that by pressing Alt-H, or please use the info and help section on the conference website for more help. For question and answer times, and we do really encourage questions, so please don't hesitate to put them in the question and answer section. There is a Q&A box in the menu bar, and please submit questions there as they could get lost in the chat. To ask a question or make a comment, you can also select the hand option on the menu bar that allows us to know you have a question. For those of you on the phone today or using keystrokes, we ask that you press *9 or Alt-Y on your keypad to raise your hand, and we will then let you know when you can unmute. You can select the unmute option or Alt-A if you're using keystrokes. Remember, if you join into the conversation, please keep all background noise down as much as possible to allow others to hear you clearly. And then I'll pass it off to Alyssa to get us started. Thanks, everyone.
Well, thank you all for being here. I just want to give you a brief rundown of April's Project Alive. It is a short-term focused effort to remove barriers to COVID-19 vaccinations for people with disabilities living in the rural areas of Arkansas, Missouri, and Montana. Rooted in the values of self-determination and self-direction, the project does not seek to persuade or convince, but will serve as a resource for those who want the vaccine and those seeking further information in order to make an informed decision. We onboarded 8 centers for independent living in the states of Montana, Missouri, and Arkansas, where the COVID-19 vaccination rates were low and infection rates were high. Our priorities were mobile vaccinations, taking the jab to the people, in coordination with local transportation providers, health departments, and trusted members of the community, from the church to the sill and everyone in between. This is an all hands on deck initiative. We also focused on identifying barriers to ensure that we do better in the future. April is utilizing existing relationships, resources, survey results, historical data, that has been conducted over the years with our member SILs, SILCs, and other CBOs. April, in coordination with the Partnership for Inclusive Disaster Strategies, is utilizing surveys for people with disability, focus groups of people with disabilities, key informants of people with disabilities, stakeholders, planning groups of people with disabilities, and public health. April is collaborating with the partnership to identify barriers, conduct training, and provide technical assistance, create a plan with each identified area and implement the plan as identified. Member centers did the heavy lifting to increase vaccination rates in their service areas. The centers that we pulled into this project were Mainstream SIL in Little Rock, Arkansas, Sales in Hot Springs, Arkansas, Southeast Arkansas Independent Living Services in Whitehall, Arkansas, Merrill in St. Joseph, Missouri, Rail in Kirksville, Missouri, Heartland Independent Living Center in Owensville, Missouri, Summit Independent Living Center's Ronan, Montana office, which is also seated on the Flathead Reservation territory, and Lift in Billings, Montana. And we looked at Montana specifically to engage in outreach to the Native American population, as many of the centers for independent living have Native reservation land within their service area. And as we all know, SILs are trusted, known providers in the disability community, and April relies heavily on SIL data, independent living plans, and consumer outreach already being done to identify the target groups. And now I will turn it over to Shaylin, and we'll hear from our partners. Thank you.
Well, this is Shaylin. Thank you, Alyssa, for that introduction to Project Alive. And as I mentioned when we got started, I am wearing a couple hats today. As I said at the beginning, I am an April board member, but as Alyssa also mentioned, I am the co-executive director of the Partnership for Inclusive Disaster Strategies. And we've been involved in Project Alive, as well as what Dawn and Marcy will share with us around their project with the World Institute on Disability from the same project source. We've been, as Alyssa said, really just working hard to identify the gaps and barriers people with disabilities are facing through things like focus groups and surveying consumers and working with our Centers for Independent Living partners that are here. And Pat Chambers is one of them who will talk about his experience from the Center for Independent Living perspective and experiences he's heard from consumers and working with folks in the community in Missouri. And my team members here at the partnership are Melissa Marshall who is our Director of Operations, and Regina Dighton, who is our Equity Consultant. And they both have been really instrumental in creating, developing, and providing trainings for our Center for Independent Living partners in the project, as well as trainings for the public health departments in each of the states that Alyssa mentioned. And they have been working really hard to make sure that that information is becoming available. And the training concept is that the Centers for Independent Living received a similar training to the public health trainings, but geared towards what Centers for Independent Livings need to advocate on a local level and to educate public health professionals on inclusive emergency planning throughout public health and vaccine equity, as well as then creating that training available for public health professionals to really identify what their legal obligations are to people with disabilities throughout the vaccination process, as well as mitigating bias, disability bias with a trauma-informed framework. I think that's a good overview to add to what Alyssa mentioned. I'd like to pass it to Marcy and Dawn to share about the World Institute on Disability and the project that they've had throughout these past several months.
Marcy, would you like to share about the World Institute on Disability, and then I will build from there onto our particular project?
I'll be happy to. Hi, everybody. I'm Marcy Roth. I'm the executive director of the World Institute on Disability and a proud member of the Association of Programs in Rural Independent Living, and really glad to be here with everybody. The World Institute on Disability is one of the oldest global disability rights organizations, founded in 1983 by Judy Heumann, Ed Roberts, and Joan Leon, and continuously led by people with disabilities for what is about to be 40 years. And we are really glad to have the opportunity to work on this very important project. I'll have a chance to talk a little bit more about this later, but the opportunity to build capacity among disability-led organizations and public health at the local, state, and national levels here in the US is really an imperative. And so I'm going to pass to Dawn, who has been working around the clock on this very important project, thanks to the CDC Foundation.
Thanks, Marcy. And I agree with you. This is all the result of a commitment on the part of the CDC Foundation. I am Dawn Skaggs, and I am the director for the emergency disaster and climate resilience work at the World Institute on Disabilities. And I've had the good fortune of leading this project and collaborating with the Partnership for Inclusive Disaster Strategies on pieces of that, and with some Department of Health representatives. WID, the World Institute on Disabilities, is a second grantee who's been working really parallel with April and doing some very similar overlapping work. When we approached this project, we knew that people with disabilities have a universally lower vaccination rate than the general public by an average of approximately 3%. And this remains consistent across disabilities, races, and age groups. So we wanted to make sure that we included a vast diversity of demographics in our work. We identified that Idaho, Ohio, and Louisiana, although geographically proximal to some of April's states, had some unique challenges as well. Similar to April's states, these were 3 states with above average COVID-19 rates, and their vaccination rates were in the bottom 20% for resident responses to opportunities. So we really wanted to look at these 3 states and see what was going on there and what were some of the activities that were happening on the ground and why were some of those things happening. We also identified that those 3 states had a vast diversity of urban, metropolitan, rural, and non-metropolitan communities, diversity of age, ethnicity, and socioeconomic status, and social vulnerability index scores. So when we reached out to those states, we reached out really specifically to people who could represent that diversity. And in Ohio, we connected with the Access Center for Independent Living, the Services for Independent Living, the Ohio Statewide Independent Living Council. In Idaho, we worked with the Disability Action Center Northwest, LIFE, a Center for Independent Living, and LINC, the Living Independence Network Corporation. And finally, in Louisiana, we worked with New Horizons Independent Living Center, the Resources for Independent Living, and Southwest Louisiana Independence Center, Inc., which is SLIC. And so we owe a debt of great gratitude to those independent living centers and SILCs. They really were pivotal in our ability to reach into the community and to get the information that was accurate and useful for us to move forward. What we did at the World Institute on Disability diverged a little bit from April's Alive project in that we really identified the abundance of historical documentation validating the disproportionate impact of disasters on people with disabilities and the ongoing related challenges. And we observed through COVID-19 that these same patterns that we see in disasters that result in people with disabilities having an inequitable, disproportionate negative outcome in their health and independence was replicated in COVID-19. And the difference was that it was expanded across time, and it was much more easily documented than in a disaster response. So we used the COVID-19 pandemic and the vaccination efforts in these states to really drill down into what happens in a disaster with health equity for people with disabilities, and using the vaccination program more as an exemplar than as a freestanding independent project. So I can touch on this a little bit later. I'm going to stop talking, but really that is in capsule what WID did with the same project, looking at those inequities and what happened at the vaccination points of dispensing, the struggles that they had with inclusion, accessibility, and effective communication, as well as some culturally competent strategies. And how do we generalize and apply those and utilize those knowledge points and that information to more effectively bring people with disabilities collaboratively together with representatives from the Department of Health and health providers? And how do we bolster the capacity within those existing systems in order to make them more inclusive and to break down some of those systemic barriers? Because we realize that's really what we're looking at, is exemplars of systemic barriers for people's ability to access equitable health opportunities in every disaster, that COVID-19 being one. So I will let someone else share at this point before I go on for too terribly long.
This is Shaylin. Thank you for that overview, Dawn. Really important and a lot of pieces. And I think it's really neat to be in a position where we have at the partnership have been able to collaborate in both projects to be able to really see some of those key components that are similar and where they also differ, and areas where collaboration can happen, as well as resource sharing across state lines. There's no reason why we can't be sharing our information and good and promising practices that are happening in our local communities to others in other areas, and being able to adapt those inclusive plans and good and promising practices as we come across them, and as we also strengthen and develop them with public health professionals and local disability-led organizations and disability leaders. I want to talk a little bit with you all about the biggest barriers that we've heard of and encountered during the project. In regards to increasing access to vaccinations. It could be around specifically COVID-19 vaccinations, but also if your project is a little bit broader on that topic, the access to immunizations and sites, and the barriers that we've seen in strengthening the relationships with public health and disability-led organizations, and how we also increase the preparedness practices and policies in public health for people with disabilities. What are some of the biggest barriers that we've seen in these three areas? I'm wondering, Regina, if you don't mind getting us started with some of your initial thoughts. I know in Project Alive, you worked a lot around the relationships with public health and getting their engagement, as well as collaborating with the local disability-led organizations that we've partnered with in the three states. What have you felt are the biggest barriers in some of these areas?
Thank you, Shaylin. Can you hear me? First of all, I want to make sure I'm heard. Okay, because sometimes this laptop doesn't like whatever. So one of the things that I noted was often, not always, but often public health just not seeing an importance, a priority in working with local disability-led organizations, almost a feeling of, we got this, we know what we're doing, and we've done it. So I think that's very, very important. And I don't mean they weren't willing to be helpful, but I think there's a tradition of government agencies, frankly, planning for people rather than planning with people. And so that was certainly something that was encountered. Many felt that, many of the representatives felt that they already had the training, the expertise, the experience, and that they'd done everything they needed to do, that they were fully accessible. And, if people needed them, they were there, and that there was nothing else to do. So yeah, that wasn't good, but that's something we've seen.
This is Shaylin. Thank you, Regina. And I'm wondering, Pat, if you might have some additional points to add to what Regina's talking about and some of those barriers that you as a Center for Independent Living in the local community in Missouri have encountered when working with public health and strengthening those relationships.
And thank you very much. The three centers here in Missouri, Rail, which is in Kirksville, Missouri, in the northeast part of the state, Merrill in northwest Missouri, both of those are major college towns, Northwest Missouri State in St. Joseph and Truman State University in Kirksville. My center, Heartland Independent Living Center, is in central Missouri. We have three primary counties that are assigned to us or service by vocational rehabilitation, that is our state entity that we work with for voc rehab. One of my counties is less than 10,000 in population. Another one, the county that in Owensville is Gasconade County. And if any of you have ever heard of wine country in Missouri, that's Gasconade County, but there is less than 16,000. And then we have Franklin County, which has become a bedroom county for the St. Louis metropolitan area. It's one of, if not the fastest growing county in the state. Its population now is about 102,000. When I will tell you there are 22 centers for independent living in Missouri. When the pandemic hit, we were all looking for information, access to vaccine. And I think Missouri was like a lot of other states, that vaccine coming in and how it was rolled out to who was eligible, how to get that, seemed like it was a very, very slow process. I know we were constantly in contact with Department of Health and Senior Services, with Division of Senior and Disability Services to try to get this information. It's come a long way. Unfortunately, it took 3 years, but now you can walk into basically any pharmacy that's inside a supermarket or whatever, and they've got, they're promoting COVID vaccinations, pneumonia shots, shingles, all of that. So it's come a long way. And I think really that the pandemic drove that. But as was mentioned earlier, Missouri is a very conservative state in the whole, and especially rural Missouri. The vaccination population in Gasconade County, my county, is still less than 40%. Mary's County, the small county, less than 10,000 people, their vaccination percentage is, I think the last time I saw, 27% or something. And Franklin County, believe it or not, with 102,000 is barely 40%. Franklin County's health department, and I hope there's nobody on here from them, but they really panicked. When people were starting to get COVID and they were calling to get information and do the mapping to where people were in contact with. About this third day after it was declared a pandemic, they quit answering the phone. They wouldn't answer emails, they wouldn't answer phones. So it was really hard to find out what was going on in Franklin County. Gasconade County was pretty much the opposite. Although they're a small staff, they did the best they could to try to make those connections, help people understand in safety. The smallest county, Mary's County, actually does not have their own standalone health department. They partner with another nearby county. So it was hard to get information from them as well. We had, and this is nationwide, people called it the China flu. They called it, everything but COVID or whatever. By and large, the attitude towards COVID was that this was a political issue and really not a health issue. And that it would go away in a couple of weeks. Now, now 3 years later, it's that couple of weeks is long past. The senators there in Missouri, Merrill, Rail, and myself, I think, and remember what Alyssa told us, and I think Regina also mentioned, we did have a lot of success in getting surveys completed and doing exactly as you all had directed us. There's no wrong answer. Nobody's trying to get information and make somebody feel like they should get vaccinated or whatever. This was a data collection, information collection process. And we had a pretty good luck with all three of us. In late May, we had a Missouri statewide independent living council, and MOSIL, the State Association of Centers, had an IL summit in Branson, Missouri, and we got a lot of surveys, probably because we didn't let anybody leave until they filled one out. But then we had an event that we were able to take part in the Missouri State Fair. They have an event every year that's called a senior fair. And so we had a booth down on the floor of the exhibit arena, and we're able to interact with folks prior to them starting bingo. You don't interrupt bingo, let me tell you. But we got some more there, and then at our the State Association of Centers, MOSIL, M-O-C-I-L, just had our annual meeting last week in Jefferson City, the state capital, and got a few more there. I know that it was difficult for us. I think, and my hat's off to Rob Honan, who is the executive director at the center in St. Joseph, Maryland, because they've got a focus group going. As Rob explains it, it was kind of just, he was at the right place at the right time in another meeting and said, well, if you're doing that, why don't we do this? I did not have that luck. But I think with getting people, with networking and getting people to resources where vaccinations were, we don't have a lot of accessible transportation here that is public transportation, unless that person with a disability has accessible transportation of their own. But we got a lot of people were able to connect with the health department and get somebody to a vaccination site, or get the site to come to them. We weren't successful in trying to work with the University of Missouri hospital system, health system, in getting a activity set up. We'd had some conversation about having a mass vaccine event at a University of Missouri football game that attracts a lot of people. That the transportation just didn't work out to get that set up. But I think that even despite the obstacles that we had with the negative attitude overall, and then being in rural areas, I'm proud of what efforts were made and achieved in trying to get information out, and with what we've accomplished to this point.
Mm-hmm.
Go ahead, Regina.
I was just going to say the other thing with public health was, in rural areas, the county public health departments, there's just so much diversity in their capacity. And so you went from everything to what you'd kind of think of as a fully staffed, ready, good infrastructure system, to one where the health department was one person in a makeshift office that was kind of like a closet, who also had another job, and they had maybe 10 hours a week for public health. So I didn't want to leave that out, and to kind of back up what Pat was talking about, people's beliefs. Project Alive isn't trying to change anyone's belief. And so, where people just have a solid belief that either, some of the things we heard, either, COVID isn't real, or this is a political thing, somebody made this up for their own political aim, you're not going, you're very unlikely to change that. And the other was, even if people believe that COVID was real, was distrust of government and fear of government. So I think all of the education you could provide, and then where's your source? The CDC, that's the government. So, that's another thing that I think really, stands in the way. And then I just wanted to mention quickly, which I think is very, very important when it comes to marginalized, oppressed people. Certainly that's us people with disabilities. Certainly it's low income, rural people, period. So, you know, there's these intersections of identity. There tends to be an outer locus of control. And I think that's, you know, our internalized oppression. So there were a lot of people that said, God or nature or fate or something will take care of it. But this is not for me to try to control.
To Virginia, your point, we learned by trial and error here, we quit referring to the CDC Foundation. We just said foundation, because there were a lot of people, if they thought that it was government, that even if we said, no, there's no wrong answers, they would not participate. So if asked, and we had to volunteer information, it was a national foundation that was behind this.
Another SIL director gave me an example during a key informant interview of a person who was homeless, sleeping outside in a tent, so forth and so on. And she brought him in and was doing like an intake and offered him subsidized housing. And when he asked and found out that the resource was the government, he said no.
This
So
is
that's
Shaylin.
how strong it is.
Mm-hmm. And you both bring up some really important points. And I really appreciate you, Pat, really highlighting some of the things that local folks in the community have expressed and shared, and some of these key points around trust and information and how folks are getting it, and informed decision making, and the different perspectives that everyone has, and making sure everyone still has that access to the information to make that informed decision. I want to pass it over to Dawn and Marcy to see if you have anything to add around barriers that you all have seen.
Absolutely. To the points that both Regina and Pat have made, the trust and the related fear and anxiety were phenomenally prevalent in what we found on both sides of the table. Interestingly, one of the areas that we initially experienced some trust issues in executing the project was with Department of Health representatives in simply getting them to take the survey, because there was assumed consequences if they were going to share things that weren't, I guess, along the party lines or in conjunction with the public presentation of their employer. And so that was a fear we did not anticipate. We managed that, and were able to do a survey with the participants, which really had a higher prevalence of providers and people who actually interacted with the community members than with those who were in leadership. And once we were able to communicate adequately that this was anonymous, that this was shared experience, and they took the survey itself was structured so that they were not necessarily relaying their own experience or their own behaviors, but rather things they were aware of within the system of delivery. And so that gave us some really interesting perspectives that were sort of some underlying currents behind that public persona of "we got this, don't worry about it." And when they were able to share without repercussion and absolute anonymity, we discovered really there was very predominantly 3 areas of perceived barriers from the perspective of the Department of Health representatives and the public health representatives. And those were, interestingly, very much in parallel with what we heard from the community. And over 50% of our respondents from that particular survey acknowledged that there was limitations in supplies and funding in order to implement accessibility and inclusion efforts that they knew needed to happen. So there was an acknowledgement that they were falling short and that there was a gap. And they weren't doing what they knew needed to be done, which I found very interesting because it tied with the fear from their perspective of a failure. And there was a roll up, of course, in terms of the people who were aware of the gaps were not the people who were making the decisions, and the people who were prioritizing the funding and the resourcing. And the other, as Pat brought up and mentioned, the other thing that we found really interesting in one of their top 3 perceived barriers was transportation. The realization that their vaccine sites, their disaster services, post-disaster services were not accessible, in large part because they were not situated where people could get to them, and there was not an adequate or sufficient or appropriate accessible transportation for the community to access the services that they knew were necessary. And the third area, which should come as no surprise to anybody, that over 50% of the respondents said was a major issue and a major gap, was communication. And their own ability to adequately communicate with the community, in addition, adequately communicate with people, specifically when they were in a vaccination point of dispensing, whether they were in a shelter or any other disaster situation, they knew their communication was lacking. 45% of the respondents said that they personally had difficulties because they did not know how to circumvent those barriers. And so they were also aware that some of those overarching accessibility communication needs, such as ASL and plain language, were not being provided by their organizations. And so it was a very revealing experience to see what they say sort of behind the curtain when there's an anonymity. There was a strong acknowledgement that the gaps do exist. And yet there was not a feeling of personal empowerment by the individuals who were providing services to be able to remedy that, to be able to act as allies within the system to make a difference and remediate some of those issues. So that was, in addition to the anxiety barriers that we found within the community, and the fears that were very predominant in our feedback from stakeholders, that there was major trust issues because of previous experiences, as well as because of perceptions. In some of the states, we did have diverse demographics that included populations that were simply not comfortable with anybody in a uniform. And so talking to or approaching or trusting that someone in a uniform that is dealing with the health of their personal body was really perceived to be an insurmountable barrier, that level of trust. And the resulting anxiety that pervaded all of our responses from the community was very, very significant. It was a secondary barrier because of the first barriers, but it was very, very strongly represented in the responses that there was an enormous amount of anxiety, even in the anticipation of having to have the interaction in those types of highly charged situations, was a compounding variable that we found.
And this is Marcy, and if I could maybe connect some of the bigger dots in all of this. I think, many people who are here in this workshop know full well that there has been a clash between our view of disability and the view of disability from public health. That's obviously a long-standing challenge, and it's no surprise that this has created all sorts of additional unintended consequences. And, when you add and, back to the issues around communication, some of the issues around communication also have included the very unfortunate use of language in messaging, which, for example, failed to identify people with disabilities, but instead referred to us as old or fragile or frail or having underlying conditions or comorbidities. And so it's really easy for people with disabilities to then say, oh, well, that's not me. I'm not old. I am old, just to be clear. But for many people, I don't even know what a comorbidity is. So certainly they're not talking about me. So there were those layers of communication disconnect. And then there were, research data that I still scratch my head over, things like people with intellectual disabilities are at, far greater risk of dying from COVID than, anybody else. I'm not a researcher, but I'm willing to bet that it's the fact that people with intellectual disabilities are institutionalized, people are served in congregate settings, and that is the reason that they have had a disproportionately high impact from COVID. So, I think as we're doing this very important work, I think it's also given us, and Dawn, you and I were talking about this earlier today, it's in a sort of strange way, it's been a gift, if you will, to look at a long onset and continued disaster rather than what we typically the window that we typically have. So, and I'm going to be leaving you all soon. So I just wanted to jump in and share some of those thoughts.
This is Shaylin. Really appreciate those important points, Marcy, and for your time today. I do know you have to leave us a little early, and we appreciate you joining us and providing your input and valuable information for folks. I do want to address a question that has come in through our Q&A, and just as a friendly reminder, the Q&A box is available for questions at any time, and we'll circle to them as the conversation allows. We have a question that comes in around the healthcare systems and doctors in particular that can be quite ableist, and how do we teach the value of the lived experience? And this person also shares that they have found it to be very cognitively inaccessible as an autistic person, and how we can work towards that. And I know on both projects, we have all talked about bringing together the public health professionals, departments, and the disability leaders, disability-led organizations, and allies in the community that are on the ground and supporting people with disabilities on a day-to-day basis, and making sure that they are coming together on a regular basis to share updates, to share resources, to collaborate on rising issues and identify what those gaps are together and address them together. And I know that is kind of a reoccurring theme throughout both projects, but don't know, Dawn, if you'd like to add anything to that, and then I'll pass it off to others.
Sure. It's the essence of the question, I feel, has a lot to do with that value of the expertise of the disability community, and sort of how do we navigate that medical model world that is built on the medical perspective, and how do we enact a paradigm shift for that? And really some of what we found in our efforts had a lot, and what we found in previous project efforts has a lot to do with not focusing on us versus them, but focusing on how do we create a shared space that honors the knowledge base of both population groups. And to that end, we have done some work and continue to do work through this project in creating that opportunity for a collective working group. And with the understanding, we're not going to get every medical provider, every health provider on board. But it's a matter of progressively switching, changing the paradigm and switching it up so that there is a shared understanding of the value of lived experience together with the value of education experience, and that those need to be married. And fundamentally below that is that person-centered planning, where acknowledgement that the individual is very familiar and is the expert with the expertise of how the needs need to be met. And that is one of the core reframing and re-educating that's at the center of a lot of the collaboration that we're working towards. And to that end, what we have identified is really that it's not a matter of one group inviting the other to their table, but creating an opportunity for a shared collaborative experience, which takes time. This is very much a progressive effort that is not something we can change overnight. We're really talking about systemic barriers. We're talking about embedded systems that are part of the core of the culture of most of our health delivery services. And so that's really the area that we have been focusing on in terms of how do we make a unified table that honors and respects and values the expertise that's brought to the table as an equitable partner. Equity and outcomes really begins with equity and perspectives in the initial outset. And that's really the area that we have identified as a potential avenue to bring the community-based organizations and the CILs together with allies within that within the system. We're always going to have those holdouts that are committed to the medical model, but there are people within the system that can be identified as allies, and making those relationships, forging those partnerships, and building upon those so that within internal conversations, the same messaging can be repeated, and we can continue to build. And I know that sounds very utopic, but that's really the goal that we're working towards in this particular strategy. Regina.
Yeah, Dawn, I was going to ask you or anyone else if you had any examples of progress or success in that effort.
Absolutely. We have worked with some cities and counties throughout the country. And I'm going to leave them nameless because some of them have participated under initial duress. But really what we have found is, as a third party, as an external party coming in as a general disability inclusion subject matter expert, we can sometimes play that role of building the relationship on both sides of the table, and for a period of time standing in the middle. And what we have noticed is one of the biggest barriers to that is communication. And beyond providing the accessible communication and plain language, it's really the use of language. How language is intimately related to culture. We're really talking about two different cultures. And so consequently, two different strategies to communicate. And I'm going to indulge myself and tell a very quick story about one of these tables at the first meeting. We had disability representatives from the stakeholders, both individuals as well as providers and independent living centers. And on the other, literally the other side of the table, we had Department of Health and Emergency Management representatives. And there was an ally in that group who spoke up to say, we really want to leverage the expertise in the disability community. And immediately there was someone on the stakeholder side of the table who said, we don't want to be leveraged. We want to engage with you. We want to partner with you. And so that sort of is one of my favorite examples of how we need to make sure that we have a common language in the middle of the table to overcome that initial miscommunications, misperceptions, and consequently trust issues that arise from that. And what we have found is that often it needs to be hosted. Those conversations need to initially be hosted by an ally internal to the Department of Health or the Public Health Office, who's willing to take that step to begin the conversations, and really bring the disability stakeholders to the table, not as experts to be heard or to be noted or to layer on disability, but as an equal partner. And it takes those very specific people who are willing to step up to say, you know, within our department, we recognize this as a priority, and we may need to reprioritize what we're currently doing to do it differently. The other thing that that person really often does, as I've observed, is they reframe disability inclusion, because that's often perceived as an add-on to the work, as an unfunded mandate, and sort of being able to talk through that, to share that this is just a different way of doing it. It's not more work. And if you're doing it right, it's really less work. You have an entire community, an entire team to come alongside you. So I apologize that I can't say in this location this happened, but that's the essence of what we've seen whenever it's been successful. Again, it's a long-term effort. Usually we see that start and not really be self-sustaining in terms of the mutual commitment for at least 6 months, sometimes more like a year. So there has to be that ally and the patience and diligence on the part of the community members to take the Department of Health representatives where they're at, in order to take them where they need to be. So that was kind of a long-winded answer. I'm sorry, Regina.
No, but thank you. And I think it is important. That third party is important, you know, that's focused on fostering communication and bringing, you know, people together from public health and from the community. So thank you very much.
Yeah, this is Shaylin. Thank you both. Really appreciate those points and those examples, certainly as a tool for folks to use to take with them. Anyone else have something they'd like to add around this question?
Sure, I can.
Yeah.
And this goes back to what Dawn said and others. But communication and networking is key in anything, but in this as well. And in having centers get into that. Heartland is the youngest center for independent living in Missouri, and we've been open since 2002. But what we find that helps us gain credibility, and therefore people that will, if we tell them that it is, you know, we're gathering information or whatever, is those partnerships that we may have with local government, county government, into the state. Those relationships with the news media. If something comes up and we have information that we can share with our local radio stations or newspapers, television, whatever the resource is, and it's accurate information, then we become a resource. And the next time something comes up, oh, it's disability related, let's talk to Heartland, or let's talk to the Merrill or Rail or whatever. It's a long-term process. You don't jump in and try to make a big splash in a little pond and think that everybody's going to remember you. It's an ongoing process, but it will get you that ability to be recognized as a valuable resource. And I underline this, the pandemic was a prime example of that, when people were wanting to know what they could do, how they could shelter in place, those types of things. We became a resource and it was more valuable. And I do think the silver lining is that it did help us expand the value of the centers in our respective communities.
This is Shaylin. Pat, you make up a really good point that makes me want to go to a question that I had a little bit later on, but I'm going to move up just a smidge and pass it to you back again. We talked about communication and trust, mistrust in government and ways of information getting out to folks. And I think it touches upon how there is a lot of hesitancy, as well as in some cases resistance that I've learned from Regina. She's really pointed that out, that it's not just hesitancy of getting vaccinated or of the information around COVID-19, but can be very resistant. People are just not receptive to the information. And Regina gave some of those examples at the beginning of how we sometimes can just do what we can to provide information and make sure that it's in accessible formats and folks can make informed decisions. But I wanted to know, Pat, especially in your circumstances in Missouri and with your consumers, areas of hesitancy or resistance that you've encountered and how your Center for Independent Living has worked to address this hesitancy and resistance.
So that's a very good question. It's, and I alluded to earlier, very conservative area, very negative. COVID was politically motivated. It was going to go way fast, all of that. But we had to use circumstances, and I'm kind of selecting my words here. Those people that weren't going to get vaccinated, COVID's not real, it's made up, it's whatever. We had to take an opportunity when it presented itself to relate to people that they work with, family members, people in their faith-based communities, and talk about situations that impacted those folks and their families and their coworkers, and how the vaccination and we use the polio vaccinations from the 60s and stuff, but you try to develop for whatever that person or that audience was, something that related to them that would get past just the COVID or whatever, but the impact that the pandemic had on people they knew, then they could make it real. Then it wasn't just the government doing this or that, but it was real. It was in their community, it was in their family. And here, and I'll speak from Heartland, we had more success because these are folks, a longtime county assessor in the town I used to live in said, if you're going to be in the public and do things, you had to go to the different meetings and organizations and do your hi, how are yous? So people would recognize who you are and that you are a part of the community. When we were able to do that with those real life scenarios and situations, we had a far better success rate than we did trying to promote the safety of the individual. You had to bring it home to them.
This is Shaylin. Thank you, Pat. You really touched on a lot of important pieces there of being that trusted source of information as the local disability-led organization in your community, and that your community members know that they can go to you with questions, regardless of what they are around anything, and that you will help them navigate that and decide an informed decision together that the consumer and the person is wanting. I'm wondering, Dawn, if you have anything you'd like to add to that from what you've seen around hesitancy.
We saw very much the same thing in terms of meeting the individuals and the community where they're at. In terms, and I think that what y'all said at the beginning of April's strategy of not wanting to change anybody's belief system, that premise goes a long way in the initial to build the relationships that are based in trust, because without that, the individuals in the community, they're not hearing anyways. There needs to be that established acceptance of it, what they're hearing is coming from a trusted source before what they're hearing is even heard. And so that really is an incredibly powerful role for the SILs in their community, because they do play that. And they can take that role as that intermediary and accept what is before we move to what we would like people to be able to do. And the other piece of that is really where it becomes what we saw, where it becomes somewhat challenging is where personal choice meets best practice, and maintaining that trust when people and stakeholders are executing their personal choice. That can be a very challenging space to be in.
That reminds me, when you talk about the word resistance, I don't know why I didn't think to mention this earlier. You know, many of the states out in the Midwest and Northern West are amongst the states that were suing the federal government for mandating that government employees be vaccinated. And so, you know, if that's what you had at the very head of your government, if your governor was signing on to that, certainly you'll see that in the heads of health departments and, you know, other places in terms of what they feel they should be doing or what they shouldn't be promoting. So on the one hand, you've got individuals who say this is the government, but at the same time, you've got the government, the state government saying later for the federal government. So, yeah.
To your point, Regina, I think it gets even messier when you have states that have some fashion of home rule. And then it becomes whose responsibility is what. And it can be phenomenally confusing from the consumer standpoint.
Really important points. Really appreciate this conversation and talking through some of these barriers and the gaps that we've experienced throughout these past several months since the beginning of the year during these projects. I'm wondering if we can shift our gears a little bit. You know, we've talked about the barriers around communication, around transportation, mistrust and misinformation. These sort of, which could be, some of them certainly are longstanding gaps in our public health and disaster-related services and programs that are impacting people with disabilities. And I'm wondering what have we seen that are good and promising practices, or what are some of the emerging or potential remedies or action steps that we can try to bridge these gaps and overcome some of these barriers?
I'd like to speak to that. In some of the tribal communities, as well as in the Marshallese community in Arizona, having the elders.
Arkansas. This is Shayla.
Arkansas. Oh my God. I thought I said Arkansas. I said Arizona.
The A states.
Alaska.
Yes.
Oh, sorry, Alabama. Don't know what's going on there. But yes, Arkansas. Thank you, Shaylin. In the Marshallese community, having the elders carry the message was largely successful, and having communities say, yes, let's get vaccinated. You know, and certainly in a place where elders are valued as being wise and their lived experience is upheld and valued. Yeah, I thought that was just very, very promising and just wonderful.
And this is Alyssa. I think you found that a lot in the Native American population as well,
You did,
is
yes.
that, you know, when you have your elders out there saying, you know, this is real, protect me, then you get the buy-in.
Yes. Yeah.
Go ahead, Dawn.
I was just going to say, to build on that, it's a phenomenally important point, Regina. And I think that one of the takeaways from that can be, you know, how do we generalize what the effectiveness of what we see there? And I think one of the strategies we can use is to really identify who are the leaders within the community. And the other geographic type descriptor of community that we see that in is a rural community. And the leaders are not necessarily the people with the titles. Often they are, but sometimes they are not. If we reach out into the community looking for who are those emotional, social, organizational leaders that may not have a title, we can garner some really incredible strength to impacting the community and their perspectives, because those, and it comes back to those trusted points of contact, those trusted information sources. Like you said, Regina, when the leader says this is a good idea, and they are already trusted and they have that role in people's lives, that carries a significant weight and impact. And I just wanted to bring that in, that if we think outside the box, we can find more of those leaders than we might initially think are there. I've known a couple moms in some of the, I'm currently in Texas, and so we have a lot of rural towns, and a lot of examples of unusual and untitled leaders and decision makers in the community. So just thinking through that, and where do we find those people?
Yes.
Pat, anything you'd like to add?
No, I think everything that is being listening, we're really all saying the same thing. We really are talking, you know, building relationships, networking, building credibility. It's a slow process, and that's something I had to learn. I was raised by an Army officer that you know, you did things and you did them now. But if you're going to build long-term results, it takes, there's a process, because if you try to do it too fast, people are going to look at you, interpret you to be as something, a flash in the pan, or you're trying to, you know, build a resume or whatever. You're really not going to accomplish the greater good by trying to ram something down somebody's throat, or an idea of something in a short amount of time that they're not going to be able to process it and accept it.
And that's part of the challenge. I think we all agree, trust building relationships take time, yet there's a sense of an urgent rush when it comes to COVID or with any disaster. You know, you want it to happen fast. And
But
I guess with that, we
that's
just
why
have
you
to
have to
say,
put the work in first.
right.
You know,
Yeah. Again, this sort of circles back to where I started, which was, you know, that COVID is really just a great opportunity to look at what should we be doing in all disasters. And it's really that key point of preparedness is not just about your go bag. Your go bag is sort of a little aside. Preparedness is community wide. It's a community culture that's built on those relationships, because if they're not there beforehand, they're certainly not going to happen in the face of a disaster. So like you said, Pat, it's putting in that legwork, expecting it to take some time, and knowing that what you're doing, those investments in those relationships have a ripple effect that is explosively exacerbated in a disaster. Because what's there in steady state is going to be there, but bigger in the disaster. And so, you know, how do we address disaster health equity? Well, the one line answer to the big question is we build those relationships when there's no disaster.
Absolutely. You know, I'm gonna make an exception to something I said about people who are resistant. The examples I have encountered of a resistant person actually receiving a vaccine were all in instances where either a wife was telling a husband, you have to, you have to take care of me. What about the kids? Okay. And one woman actually said, she goes, I guess I just, you know, whatever, nagged him into doing it. I cried. But whatever, those emotional connections, those important relationships where someone said, do it for me, got results from someone who at first said, nope, it's just the government, they're lying, da 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 da. And the other were grandmothers saying to their grandchildren, you could not come see me. I will not come see you. You know, if we're going to continue this relationship in the way we want it in person, you will need to get a vaccine.
This is Shaylin. Really appreciate you highlighting that, Regina. I also have experienced quite a number of grandparents who have said they have had success with family members getting vaccinated because of that exact example. Do it for your grandma, do it for your grandpa, do it for the family. And you know, those are things, those are avenues that work, and the way that we get information from trusted resources and valued people in our communities and our support networks, and can really be a game changer when it comes to these types of things. Really appreciate that. I'm wondering, you know, we talked about how it can be difficult to maybe connect with public health departments and the right person, for instance. And I know it's been a barrier kind of in different ways in both projects of connecting with those local health departments, depending on, and this is very much by state and certainly then by locality. But what are some ways that we can work towards, you know, reaching those people that we need to reach, and what can we do when we continue to reach those roadblocks that don't allow us to contact the right person, to achieve the goals, to collaborate with public health as we want to and need to? How can we work towards that barrier of really connecting and collaborating with the partners on an equal level, like Dawn was explaining earlier? Whoever wants to go first.
I'll put my little 2 cents in. No, I certainly was not always successful. One of my methods was just to keep calling, just stay on that website and look at anything that might be relevant. Is it, you know, is it under disability? Is it under disaster? Is it under community health? Is it under what, maternal health, whatever? Because, you know, sometimes it would just be no call back, or you might get a response email and then no, never mind, no, thank you. In one instance, I was finally able to make a great connection of somebody who was really dedicated, wanted to do it, but then to find out she had a temporary position in public health and then went away. But I guess part of what I'd offer is to keep at it. The other was to, in terms of people in the community, people in the CILs, people they knew, to kind of, you know, who do you know in public health anywhere that might help make a connection?
Regina, here in Missouri and all over, there are, which is perfect for independent living centers, community coalitions. You know, whether it's a monthly or quarterly or whatever, and organizations that come together just to keep up to date, here's who we are, here's what we do, these are new programs, we're doing this, we're not doing that. In Gasconade County, my county, Heartland hosts that. As a matter of fact, tomorrow we're not doing the hybrid in person as well as virtual, but you have those, the partners that you may not, but if they see you or hear you once a month and quarterly, and you're talking about what's going on, and maybe there's some things that you can partner with them. Again, it's a long-term approach, but it's credibility. They're seeing you, you're at meetings together, you're sharing resources and ideas. That's for us what the Gasconade County Health Department has really helped us. They closed their office here in Owensville for a while and donated a number of pieces of equipment to us. And then we've been able to help them get, forward messages out and link vaccination dates and whatever, and share it on our Facebook page or on our website. So it has a relationship that is growing, especially in the last 3 years.
I love those ideas, and just wanted to put my 2 cents with Pat's and Regina's, so we'll have 6 cents. And really in support of that, sort of the 2 concepts that come to my mind are, throw a broad net. As Regina was saying, being persistent maybe outside of the box. There may be people that we think are the appropriate points of contact that we want to get a hold of, but that may be where we end. That may not be where we start in terms of connecting with somebody. And it might start with people maybe in public health, maybe someone in a different department that you work with every day. Maybe it's in transportation, maybe it's in emergency management, maybe it's in behavioral health. But starting somewhere and building on that relationship to sort of weave that net to get to where you want to. And to that end, I think we often, it's a tendency when we have goals and we have destinations of what we'd like to achieve, it can be tempting to be laser focused on that outcome. And sometimes it's helpful to start that process by just being there, not being there for a purpose, not being there to fill our goals necessarily or create this relationship, but just being there. Like Pat said, becoming the familiar voice, becoming a trusted source of information, merely by the human to human relationship. And what we see sometimes, which has, a couple times already been referred to in this conversation, is people wearing multiple hats. And you may not currently have a relationship with someone in public health, let alone the right person in public health, but you may sit beside somebody during bingo, and that relationship can lead to something else, or they may also wear another hat besides your bingo partner or competitor. But just really throwing that broad net and thinking outside the box in terms of creating that network of people, and then layering onto that, what are people's roles and responsibilities, can be feel like a more indirect, but can actually be a pretty expedient way to address that. The other really quick thing I wanted to add that Pat made me think of, which is coming to them with where are their priorities. A lot of times we're acutely aware of where the gaps are. And what we discovered in our project is there's a lot of people within the system who are also aware of the gaps. And taking the strategy of how can we help? We're here to support. We're here to bolster what you're already doing, rather than we're here to fix what you're already doing, can go a very long ways.
Really important points. Thank you all. This has been a really great conversation, and I know it could continue for many hours probably. I just want to take a moment to also just extend our thanks and gratitude to the CDC Foundation for funding these projects and making sure that this is a priority area and that disability-led organizations are at the forefront of these projects. It was one of the requirements and is certainly something that we encourage and are so glad to see on every level and certainly from top down. So just wanted to take a moment to acknowledge the funder of these projects. And although these projects are coming to an end at the end of this month, the work certainly continues, and particularly the work at the local level that folks like Pat and others at Centers for Independent Living and other stakeholders in these projects are continuing from here on out. I'm wondering in these last few moments, I haven't seen any questions, and don't hesitate to pop any in there if they come to you. But just want us to go around the table, so to say, and see if there's any last words folks would like to share, any success that you would like to mention that happened through this project.
Well, I don't mean to be constant. I first of all want to thank Sheila, you, Regina, and especially Alyssa for allowing Heartland to be a part of this. As Alyssa, we were not one of the original centers that was thought of for Missouri. Another center I understand was contacted and they did not want to participate. But it's because it's something different, it's a learning process. And sometimes you can get stagnant and stale. You do you have your programs and services, and even though you set new goals or whatever, this was that outside the box opportunity for us to get involved. And I sound like a broken record, but to network and to learn about resources that we normally might not partner with or think about. And the pandemic did that so many ways. But I do want to thank those of you that made it possible for Heartland to be a part of this project here in the state of Missouri.
And this is Shaylin. If you don't mind me adding, Pat, I just can't help myself. A success that has come out of directly from your work in Missouri is that although we would hope for many more, we were able to successfully ensure that one person got vaccinated at a vaccine site that you all helped coordinate and make sure was available at a public event. And one shot is a success, and it certainly impacts many more from there. So I just really wanted to highlight that for everyone. Regina?
Sorry, it's only one that day.
No, but I was glad that one person got there, and Pat really stuck with it, and the person who was the temporary employee with Missouri Health was, really helpful in getting that. So it was good, and in a sense, there was a success, I guess, in at least increasing communication from the central state health department down to a rural county level.
I think that's sort of the area that I think of as a success as well, is that increase in knowledge, the ability and the opportunity to provide training, to provide education, to increase the knowledge base of everybody who's been able to participate in the project. And to echo your sentiments, Shaylin, that CDC Foundation's commitment to this and to knowledge dissemination that can be sustained has really been a significant contributor to what I referred to before as that paradigm shift. And I think that's a great takeaway and a success that both projects have been able to disseminate that information and to provide training and increased awareness. Yeah.
This is Shaylin. Thank you all. I really appreciate this conversation. And I know we've gotten some reactions as we've been talking, hearts and clapping emojis and different things coming through from folks. And I do want to also just add to the point of information and educational material. I do believe it's safe to say for both projects that at some point in the near future, once these projects are officially to an end, that those information materials will be available to folks more widely across the nation. So certainly will be something that we'll be able to share and everyone can use as a resource moving forward. Really appreciate everyone's time. We have a few minutes left. I want to make a note of something that was added in the chat from Alyssa early on in our conversation. As we've touched upon COVID-19 and the pandemic a lot here, there will be another opportunity to discuss and hear tomorrow from the keynote speaker on addressing long COVID, living in the long COVID era, diagnosis to disability and everything in between. And that starts our day off tomorrow at 9 a.m. Pacific time and 12 p.m. Eastern time. And I'd love to pass it over to Alyssa for any closing remarks.
Thanks, Shaylin. Yeah, I just want to reiterate a big thank you to the CDC Foundation for funding us and letting us take the lead in this project. And I'm so grateful to our centers who participated and the partnership who I leaned on a lot throughout this project. And I'm so glad that WID was able to join us today and disseminate on what they found. I found that, you know, being able to reach out to other funded organizations was just really helpful. And so as the lead on this project, I'm just personally so proud of the work that we've done, and our contribution to the collective is invaluable. And, you know, as we all know, if we don't, you know, shove and elbow our way to that table, chances are we may not even be at it. So I want to thank everybody for being in this workshop, everyone who participated. And I'm just really thankful and proud of the work that we've done.
This is Shaylin. Thank you so much. Yes, Regina, I'm clapping as well. And it's really exciting to be at this point. You know, it feels like it was just yesterday that it was the beginning of February and we were all putting all of the information together to get these projects rolling. So I am so thankful for all of you and your partnership and collaboration and the ongoing work that we continue each and every day together. This is the end of our session, but I do want to let folks know, please take some time as you can to complete your evaluation form when the webinar closes in just a moment, so that you can let us know that how we can continue to improve and keep providing training that is most useful to you. And thank you all again for joining us. And we look forward to having you join us for the next session that starts at 12:30 p.m. Pacific time, 1:30 p.m. Mountain time, 2:30 p.m. Central Time, or 3:30 p.m. Eastern Time. And it looks like we have 4 different sessions that you can choose from at that starting point when we get back together in the next half hour. So thank you all again for joining us, and we'll see you at the next one. Thank you to all of our participants and to our interpreters and captioner.